Firstly, a confession. I'm not going to share with you any clever graphs showing workforce pressures and productivity opportunities. There's a lot of material out there from various think tanks that can give you all that. Rather, I want to start with a story, share with you an experience. Recently, my mother was admitted into hospital after a few days. Thankfully, she was discharged. And what was interesting, I asked her how her experience was. And interestingly, she didn't mention her quality of treatment. What she remembered was the kindness, empathy, and the warmth the staff towards her. And that reminded me that healthcare is very much a people-to-people business. How staff communicate, work together, interact with patients, determines the quality and efficiency of care. There's an inherent trust in the relationship. So bringing the best out of staff is key to delivering better outcomes. But how are they feeling? So here in England, according to a recent survey of NHS employees, only 61% on average stated they would recommend their trust as a place of work. And the satisfaction is lower, with 1 in 8 leaving the service. And we've also seen here in recent strikes, there's a generational shift in perspectives of the health service as well. And then there is the ongoing demand and capacity gain. For example, WHO, World Health Organization, is estimating the healthcare workforce is going to be increased to 84 million by 2030. That is 30% growth from the numbers back in 2020, which is 3 times the rate of population growth. Here in UK and England, the default response to the healthcare pressures is more people. And it's predicted that to be increased from 1.4 million to 2.3 million by 2036, 2037. But is it just a game of numbers? Actually, let's take a slightly different perspective. Currently in England, we have an extraordinarily diverse workforce. 1 in 4 come from ethnic minorities, and a further 1 in 5 are foreign nationals, representing over 200 different nationalities. Let's just pause for a moment and just think about that. That's a huge variation in training, perspectives, possibly cultural values and motivations. And in terms of, as a CPO, looking to develop a people plan to improve the workforce dynamics, one size clearly does not fit all. We need to take a more nuanced, localized approach. So how are organizations typically responding to this challenge? Next slide, please. We've taken a look at hundreds of organizations over the past few years, and looking at how organizations are pulling together their people plans and thinking about the initiatives and activities put in place. And typically there are 4 buckets of activity: corporate in terms of performing HR functions well, regulatory compliance, new ways of working, and staff well-being, focusing on sickness and retention rates and so on. But the focus predominantly is around staff type, numbers, bands, and very much driven by the commissioner or regulator perspective. And what complicates this even further is organizations typically have lots of other plans as well, from clinical strategies, estates, digital, and so on. Connecting all this becomes quite a complex picture. But if you put a perspective back onto the individual in the organization, how much of all this activities actually make an impact of the day-to-day work? What's really clear is people planning is nonlinear. Let me explain that. Next slide, please. So if you take a systems thinking approach, people planning is at the core of an organization, not a sideshow. People planning is about balancing out between what the population needs in terms of healthcare, the services we provide, and the staff we need to provide those services. We know the nature of demand has been changing over the decades, as has disease prevalence, lifestyles, and there's a growing impact of inequalities in communities. And to add to that, technology, and recently generative AI, is also having a massive impact on how consumers access healthcare. To meet this changing, growing demand, we have services in buildings and in community. But the question is, how have these changed over the decades? Some would argue that we still operating in the same old ways we were doing in the 1950s. With that in mind, to run these services, we have the workforce. Keeping them well, motivated, incentivized is critical to deliver quality of care. And this requires investments, and I'll come back to that. That's a really critical point. So there's a continuous balancing act to do here, balancing new ways of working, capacity, skills, quality of care, use of resources. Essentially, it's a system, a living, learning organization. So how can we do people planning differently, where the focus is on the individual? Next slide, please. What if we use the data which is already available within organizations and use it differently to create those human stories which make up the workforce? And there isn't one size fits all. There is not one particular segment. What are the different stories and variations? And based upon that, can we really understand what the needs, wants, motivations of those staff are, how they differ, and then come up with value propositions, ideas, solutions to meet those needs? What colleagues will be shortly discussing with you are examples of how this approach can be used to create value within an organization, how it can be used to create value within a health system, but also how can we use this approach to create a concept and idea of continuous improvement by becoming learning organizations. So I want to leave a final thought for you. Just reflecting back on what Dame Jo was saying about staff being the core, staff being the key asset within healthcare organizations. And they are the biggest spend, sometimes up to 90% of an organization. They are essentially key to better care and outcomes. So the question really is, if you look at your organizations, how much of the £1 your organization spends is spent on developing and nurturing its people? And we've done quite a lot of analysis on this, and we can share this later on, but I just want to leave a thought in terms of how much of that is spent on nurturing and developing people. Thank you.
Oh, thanks, Naeem. Thank you very much indeed. Your 7 minutes is gone, but just looking at what you've been saying to us, you're clearly making those connections between demand services and workforce. And I just wonder, having said all that, what do you think this means for our chief people officers who are working in organisations? How do they need to use data differently and adopt a different approach?
Thank you, Jo. I think this is a great opportunity for CPOs to connect and have different conversations with colleagues around the table. So I think one of the challenges always has been is we think about data in organization in silos. So there's always a quality perspective, there's a workforce perspective, there's an activity performance perspective, finance perspective, and so on. But actually, if you think about staff are really our means of production. So what staff do impacts quality, impacts the way we provide care, the efficiency in providing care. So from CPO's point of view, they have the data. The question would be, how can they connect the data and their stories with colleagues in finance, colleagues in operations, divisions, so on, and start creating a single version of truth? And that can be done. What that does is actually allows CPOs the opportunity to simplify their transformation agendas, but also make the best use of very scarce resources. Because one of the things which we all, also health systems are facing with right now is the challenge of resources, investment, and money. So there's an opportunity here. How can we do things differently where small changes make a big impact? And that comes from connecting the dots between the different genders across the board.